Welcome, NSFers. I am glad to see so many of you here this morning. We have a wonderful speaker who I know many of you will be very interested to hear, and I'm going to very slowly hold up, oops, if I can, there we go. The End of Epidemics, a very timely book that came out in 2019. With Dr. Quick this morning, we have our very own Keith Hansen, who will be giving a brief intro. We have Mike Matthews with us on our panel. As many of you know, Mike's the Protective Security Agent for the state of Nevada from DHS CISA. And we have Jim Wilson with us, who is communicating with Jono Quick about the connection to what's going on in Nevada. And we have Amanda Kirk, who is with us, who works with Dr. Quick, and she'll be listening in to hopefully capture some good articles about this from this talk. So with that, I'm going to turn it over to Keith to do a brief personal introduction to Jonathan Quick.
Thank you, Maureen. Yeah, it is my pleasure to introduce Dr. Jono Quick to our NSF audience and family. He was trained as a medical doctor and has become a distinguished expert on endemics and pandemics from global disease. His detailed CV is available to everyone on the website, as well as in the introduction for today's session. My wife Margie and I were in North Carolina last December, and we had lunch with Jono and his wife Tina. We became friends back in the mid-90s when we were all living in Geneva, Switzerland. At that time, Jono was working with the World Health Organization. I was just across the fence in the US mission to the UN in Geneva, negotiating the Comprehensive Nuclear Test Ban Treaty. Eventually, we all left Geneva, as unfortunately it has to happen from time to time. Jono and his family had lived previously in Pakistan and in Kenya. He traveled to many countries, very much involved and focused on global disease issues. He also worked for the Public Health Service in the US with an Indian reservation in Oklahoma. Jono went on to Boston from Geneva and eventually to North Carolina, where he is now teaching at Duke University, but still doing a lot of research, a lot of discussion on pandemics, et cetera, et cetera. And of course, the COVID-19 has been a great forum for that. But let me talk about Tina a minute, because some of our audience would be interested in her expertise, having raised 3 young ladies overseas in various places, South Asia, East Africa, and then in Switzerland. Tina was very much seized with the third culture kid issue, which they of course dealt with. And she has published 2 books. One is The Global Nomads Guide to University Transition, and the other is Survive and Thrive, the International Student's Guide to Succeeding in the US. So I'm thinking of our colleagues at UNR who would be interested in Tina's expertise and so on. She's a frequent speaker and obviously has thought a lot about these kinds of issues with young people crossing cultural barriers for education and other purposes. Jono gave me a copy of his book at lunch last December, and I said, well, isn't that nice? The End of Epidemics. It'd be great. Isn't that nice that they're all over? Then here we are. But I told Jono at the time, I said, it'd really be great to have you speak to our NSF audience at some point on your background and so on. Little did we know at that time what this was all going to turn into. And so it's very timely. And Jono, we're just grateful that you're here, at least virtually. And we look forward to hearing what you have to say and what your insights are, not only on the current pandemic which we're dealing with, but what about the future? As you say in your book, it's not a matter of if, it's a matter of when we get hit with these things. So Jono, thank you for being with us, and over to you.
Okay, Keith, thanks very much. And many thanks to Maureen McCarthy, to Jim Wilson for joining us, and to Mike Matthews, and to the National Security Forum. It's clearly an issue whose time is here. As Keith said, I started my practice, my medical career as a family doc in Oklahoma, and after a few years delivering babies and taking care of gunshot wounds and snake bites, I decided I liked having whole countries as patients. So spent the career in a nonprofit global health group and the World Health Organization, and now at the Rockefeller Foundation. So my deep interest in pandemics actually goes back to, and the inspiration for the book that was mentioned goes back to 2014. And at the time I was heading up the global health nonprofit Management Sciences for Health, about 2,500 people from 70 different countries. And we had a team in Ebola. We actually had teams in each of the countries in West Africa that got quite involved in that outbreak. And I remember vividly sitting in our staff meeting. We did a global staff meeting connecting with our staff that were in Liberia at the time and others around the world. And I mean, having this sort of sense of just fear. I mean, I'd never been in a situation before where the helpers, the doctors, the medical team feared for their own lives. And then realizing that it took 4 months for the world to wake up to this. And this wasn't the first Ebola in Africa. It was the 23rd. In the decades since Ebola was discovered, there'd been 22 previous outbreaks, all of which ended with less than 1,000 cases and far fewer deaths. And we started developing in early 2014. By August, it really exploded, and the world finally took notice. And so there was a lot of effort coming in to support and to respond to that and turn it around, which eventually we did. But I stepped back and said, where are we going to be 3 years from now? Because I thought back on how long it took us to get going on AIDS, and how during the bird flu outbreak and scare in the mid 2000s, there was a lot of promises made, and all. And then my time at WHO in the early 2003 with the first coronavirus that went global, the Sars epidemic. And what I feared was that we would fall back from our peak of panic into the trough of complacency and neglect. And so I asked myself, I decided to take a deep dive into the last century pandemics to ask the question, how can we keep these outbreaks? Because there are going to be outbreaks. As Louis Pasteur said, the microbes will always have the last word. But looking back over the last century, what became clear was, to a very large extent, the difference between a local disease outbreak and a catastrophic regional epidemic like Ebola or a global pandemic is human action, or very often inaction. So just taking us back to 1918, the 1918 pandemic came right at the end of World War I, quickly spread through the world, and killed somewhere between 50 and 100 million people, 600,000 in the US. President Wilson was so focused on the war effort that he would not, and so concerned about the sort of the war implications, there was no public communication about influenza, and no federal resources were allowed to be used for the response. So cities throughout the country were basically on their own. And there was a fourfold difference in the mortality among different cities. And some of the lessons that came out, and it actually took until really the 1990s before we really looked at this was that those cities that closed earlier, that responded earlier with more sort of interventions and kept them in place longer, did much better. And a great example is the contrast between St. Louis and Philadelphia. Dr. Max Starkloff, the city commissioner in St. Louis, had this concept, intelligent citizen cooperation. He met regularly with the press. He got all of the business community, the teachers working together, and they ended up having half the rate of a city like Philadelphia, who had a very well-intentioned Dr. Wilmer Cruson, but what was sort of not experienced and prone to action. Smallpox. So smallpox was one of the worst scourges in human history. Killed about a third of the people who were infected. Killed about a third of the people that it infected, and scarred and blinded many of the survivors. By 1950, we had eliminated smallpox in Europe and North America with vaccination. So the first director of the 2-year-old World Health Organization, 1951, Dr. Christian Boyd from Canada said, let's do for the rest of the world what we've already shown can be done in Europe and North America. It took 15 years, 3 meetings of the world's health leaders before they voted to eradicate smallpox. And the person who made that happen is the fellow in the middle, Dr. D.A. Henderson. Once they voted and it kind of gave way to D.A. Henderson's efforts from the CDC, it took less than a decade to eradicate it, and 30 to 40 million people, mostly the poor and voiceless in Africa and Asia, died while the world's health leaders were talking. The case on the right is the last person to have smallpox. SARS. So SARS was the first coronavirus to go global, as I mentioned. Came out of from a bat in rural China to that little cute animal there is a civet, a delicacy meat from China, and from there to a rural farmer who's taken care of by a Chinese doctor, who ended up on the 9th floor of the Metropole Hotel in Hong Kong. And within a matter of weeks, that virus had spread to 27 countries and infected 8,000 people, killed about a tenth of those, roughly 800. And a quarter of the survivors had lifelong respiratory problems. The Director General at the time, Dr. Gro Brundtland, got reports, and they were WHO was getting early warnings from one of the earliest early warning systems, a so-called web crawler that's at the time was just looking for news reports. Early on, they knew something was going on. China didn't say anything about it, but once WHO sent a team out, actually. Carlos Urbani, who ended up recognizing that this wasn't a normal flu, he ended up passing away from it. And on a Saturday in March, the head of the infectious disease group at WHO came to Dr. Brundtland, the Director General, and said, this is killing health workers, canary in the coal mine for a new outbreak. It's crossing borders, you gotta do something. So without asking any of the then probably about 190 members of WHO, she called a health emergency and mobilized, and within 6 months, that virus was put back in the box and hasn't come back since. So AIDS, another example of an outbreak that started, this was a different sort of a virus. 3 out of 4 new viruses come from an animal to human jump. This jump actually happened in the early 1900s, probably around 1920. as far as we can figure from the kind of genetic evolution, and spread. The first cases appeared in the U.S. and in Haiti and elsewhere in the early 1980s. This is now fast forward. It took 20 years to develop an effective treatment. The pictures there are from the year 2000, almost 20 years after AIDS emerged. The same person, 3 months apart, with treatment, TB and AIDS before treatment, after. President of South Africa said, "I don't believe in that AIDS treatment," stopped it in his country, and the consequence was 500,000 deaths. And that was denialism, the AIDS denialism, was finally stopped with some activists. And in what has been one of the greatest presidential decisions, President George Bush, in the State of the Union in 2003, introduced the emergency program, which at the time AIDS, although treatment was available and made such a difference, it was a death sentence in the South with almost no one on treatment. So in a matter of a decade and now 2 decades, we have over 17 million, probably close to 20 million people on treatment. So those are just some examples of what happens when a new virus gets out of control. AIDS was the first new human pandemic virus of the 20th century. SARS was the first of the 21st century. And we look around and we realize that we have an expanding web of risk factors, all of which contribute to greater likelihood of viruses transferring over to humans and spreading through the world. So we really are at a risk of being in a century of pandemics. So if we look at what are the pandemic threats, there's no mystery. Well, there's a little mystery, which I'll get to in a minute. But basically, this is a list that I've been using for the last 4 years. And the threats are known. And there's been a lot of work done. And again, I think, Jim Wilson has seen this over the years and some of the early signs. So the coronavirus was always on the list of the most wanted viruses. Pandemic flu, we're behind on getting a universal flu vaccine that really works for all flus. That remains because it's such a mercurial virus, a challenge. There's a term that was WHO's coined, disease X. Basically, the reality, if you think about it, AIDS, that is a virus which we haven't seen before in humans. AIDS was the disease X of the 1980s. It took a while to figure it out. Ebola was the disease X at the time when it first appeared. Nobody knew what it was. SARS was the disease X of the 21st century. So we need to be prepared for unknowns. And bioterror agents, I won't go into that, but those remain a threat. Distinguishing between global pandemic potential viruses and those regional. Ebola set Twitter records at the time because of that fear factor and the shock of the blood running from the eyes, as they say. But it was never going to go global. So those are the viral threats. And what we see looking back is exactly what we're experiencing now, is this pandemic cascade. Pandemic viruses kill 3 ways. The virus itself kills, the disruption of the health services kills, and it often kills as many or more people because of disruption of vaccination services. We saw this in West Africa, and we're seeing it now here with routine health care. Cancer patients that aren't getting in, and other sorts of effects on health seeking. And the other thing is, we know from the 2008 financial crash, which wasn't a viral pandemic, But just in Europe and North America, 250,000 extra cancer deaths were associated with the disruption of care because of the economic effect on its own. When we look back at 1918, remember that fourfold difference between among cities? Half of that difference was explained by three things. Air pollution, measured by coal consumption, the health status before the outbreak, and poverty. And we're seeing, again, the same thing, that pandemics really amplify the social disruption. So trying to distill, I mean, as a family doc, my first thing I want to do is a diagnosis, but the next thing is I want to know what we could do to make the patient better, or ideally to help the patient from getting another illness in the future. So the whole question, can we make the world safer? We're going to have the outbreaks. Can we keep these from exploding into catastrophic epidemics and pandemics? And so looking back and trying to pull out and digest in a digestible way, what were the key sort of themes about actions that we can take to reduce the chance of these outbreaks boiling over? And it boiled down into these 7 different areas. And I'm going to talk not about all of them, but I'm going to talk about 3 or 4 of them, 4 or 5 of them that I think may be most relevant. So key thing, house on fire leadership. I mean, urgency, decisiveness, courage, resilient systems, really active prevention, the whole communication area, innovation, invest wisely, and a critical factor is citizen activists, that when the health leaders and the political leaders aren't taking action, to be able to raise the alarm. So let's look at the whole idea of resilient health systems. So the world, the nations of the world first started talking about sharing information about infectious diseases 150 years ago. And one of the rights and the responsibilities that came with to the World Health Organization was, when it was created in 1948, was the obligation and actually treaty authority to be able to set the rules for the so-called international health regulations, which set out what countries are expected to do in the time when you have a highly contagious disease. And it was very clear in these international health regulations that the objective was both saving lives and minimizing economic disruption and travel disruption. So there was that dual objective to begin with. It took the world's health leaders until the mid 2000s to actually start to take those international health regulations, which do have the force of international law, and turn it into clear, specific criteria for what does it mean for a country to be prepared. So when you wonder why countries weren't prepared, it's as surprising as it may seem, there wasn't a clear definition of what that meant. The next thing is, one of the rules in global health is, and one of the kind of rules of thumb is, what gets measured gets done. I guess it's true in most places. But that meant turning this into a measure. So now there's a scorecard for 195 countries of their preparedness. The next thing that's really key is breakthrough innovations. And we talk a lot about this in the book, Warning Systems. One of the things that a clear lesson from Ebola was how important it would be to have rapid tests. We saw how dramatically it changed hospital care when they could triage. Rather than wait a week or 2 to get the test, they could triage right there, keep the sick separate from the well. And we came into the COVID with, yes, we had good lab-based tests and all, But the rapid point of care tests, it's taken really 6 months to get going. And in the last few weeks, we've really seen the scale up of, or the introduction of some new point of care tests. But those are nowhere near as available, and we can talk about that later on. But it makes all the difference to be able to identify a case, isolate, get that person out of circulation, find their contacts, and that's a critical part of containing the outbreak. Vaccines, there's been a really concerted effort to compress the 15-year and then 5-year down to 18 months. And it's actually been done in a very purposeful way. And that's something else we can come back to if you want to talk about. But there's a clear strategy on how do we preserve the safety, efficacy, quality standards by strategically combining the phase of development, overlapping steps. So you're building the factory before you even know which vaccine you're going to have, working closely with the regulators. So innovation has been a really key, and is a key part to moving ahead. The other thing, and this is the cycle of panic and neglect that I talked about at the beginning. It happens over and over again. You have a SARS, you have an Ebola, you have literally thousands of pages, I'm not kidding, thousands of pages of reports and all, and commitments of billions of dollars. But basically, once things get going, or once the headlines are gone, everybody's safely home, then it tends to get forgotten. So after 9/11, we in this country, the issues that we're having now with the response to coronavirus didn't start in January. They didn't start 3 years ago. They've been going on for 20 years. And the case in point, the Public Health Emergency Preparedness Fund, something set up right after 9/11, well-funded, started trickling down. Avian flu came back up again. Then when the Great Recession hit and put pressure on the budget, we destaffed and defunded 55,000 public health workers throughout the country, mostly at the state level. And it's not just here, it's a global thing. On the right there, you've got the promises that were made after Ebola, 2014, for global health security. This is a major effort among countries to really define and monitor and work to improve our safety against bioterror episodes, but also against pandemics. So this cycle of panic and complacency, it's the politics and economics of now. And it's partly our fault as a voting public, because we definitely will hammer a leader who is perceived to have responded poorly to a disaster, but we don't in any way reward prevention. So the cost of making the world safer is actually a pittance compared to the cost of leaving it as unsafe as it is. And we looked at what it would cost to upgrade health systems in the low resource countries, what we need to put into really purposeful R&D so we have rapid diagnostics, so we're farther down the line on vaccines, and then be ready for emergency response. The next area is communication. So the story that has come out to the West from the 2014 Ebola outbreak in Guinea, Liberia, and Sierra Leone was that, you know, the governments were had a lot of corruption, the health system was a mess, and people didn't trust the government, and all of that's pretty true. I mean, I've been in each of the countries, and I could say they're tough places. The story that's not told was how quickly the outbreak was stopped, not because of all of the outsiders that came in. They were very helpful in the treatment, but it really turned around when once people from the community understood what the problem was, because this was in a different way than coronavirus, but very similar in the sense that it was human behavior was the only thing available to stop the outbreak. And so once The traditional healers were brought on board, and you know they wanted to be on board. They saw the death in front of them. Once they were on board, once you got the religious leaders on board and the 4,000 mama queens, the market women, and you had trusted messengers. One of the stories that Muhammad Jallow, the social scientist, the Sierra Leonean social scientist that we interviewed for the book, one of his stories is about visiting, once they got their communication going, visiting a rural community, and they were meeting with the sort of the grand dame of the town, and she said, you know, I heard this stuff about not touching the dead and, you know, burial and all that, but I didn't believe any of it till my sheik said it. It's the messenger. And so that's one of the really critical lessons there. So there are some basic communication principles that were developed first out of Sars, and that are taught to governors all the way down to county health leaders and all, that just how you communicate. And these communication principles are good for school principals who may have to be communicating about outbreaks in their school should they happen, business leaders. And so just a couple of things about communication in pandemics. One, we're all, one way or another, COVID-19 communicators in our community. The message needs to evolve with the pandemic and reinforcing the helpful messages, but also there's always going to be these unhelpful, untrue messages. And one of the other characteristics is when you're working with a virus that is new, the science is going to involve. It's not that science that science as a discipline is wrong. It's continually learning. So that means we need to continually update the messages. A good example is what we've had with the issues around masks. We've talked about trusted resources. Social media is a double-edged sword. We know that it amplifies a lot of false information, but it also gives us a window into what people are thinking and gives us an opportunity to counter those messages. And the backfire effect is a concept that comes out of first experience in campaigns and then public health. When somebody, and the classic is with the anti-vaccination community, when somebody holds tightly to a belief and is ego involved in it, the more you try to give them facts, the more tightly they hold the belief. And so that's where it's really important to get the right messenger. It's not just a kind of a bullhorn from the Capitol, but it's getting the opinion leaders in the community, and those are key parts of it. So some examples of this house on fire leadership. D.A. Henderson, CDC official who kept at it with smallpox, and one of the reasons why it took so long was because there were other public health leaders who didn't believe it was possible, and he kept saying, yes, we could do it. We've talked about President Bush. Josh Busby, a political historian, has looked at the decision, and it wasn't a political decision. It was a moral commitment, and has written a book about the fact it was a moral commitment. Grover Brundtland being decisive. Another important feature is adaptability. So President Johnson Sirleaf, who was president of Liberia during the time of Ebola, and they were really struggling because Ebola really took root in a slum called West Point, and it was causing real challenges. And our administration said, "Look, we need to block it up. We need to seal it off with the military." So she said, "Okay, we'll do that." It was a disaster. So they backed off, and she said, "Okay, tried it, didn't work. We need to do something else." Persistence. through Ebola, Joanne Liu, who is a Canadian pediatrician who headed up NSF, was 4 months trying to convince people, raising the alarm. So that's a sort of leadership which really makes a difference in pandemics. So we've talked a lot about some of those key things that we need in place in order to stop a pandemic. I said I'd talk a little bit about the COVID-19, the last 6 innings. So one thing that's, I always like to look at epidemic curves. So this is basically the daily case count. Just for smoothness, it's a 7-day moving average. And we know we don't have a vaccine. We have treatment that is reducing the death rate. But the tool that we have is our own human behavior, much like Ebola, much like 1918. And the striking thing is that, in fact, countries and states have been able to push it back after sometimes huge surges. I mean, we saw Italy. Italy got wrong-footed and took a little while to put measures into place. But it's really clear if we look across, and these are just some examples, that it is possible with concerted effort to get it back down. There are going to be bumps. Spain's having a significant one right now. They're contrary to some magical thinking. Staying indoors for 3 months or 2 months didn't change the virus. There's been some mutations, but none that have significantly, as far as we know so far, changed either its deadliness or its contagiousness. So the tools that we have now are basically the ones that we've been hearing about. It's distancing. 3 meters of distance reduces the spread 50%, 1 meter, 3 feet, 50% reduction in the viral density, and 6 feet, 90%. Face coverings took us a while to really get the information on that, but the data is stronger and stronger. What we saw 2003 was SARS. It was really clear that super spreader events and super spreader individuals were a major source. And that's where we've seen the biggest outbreaks. In some states, that was the majority of new cases. It was super spreader events, that is close confined spaces in nursing homes. And we've got workplace and school adaptations, testing, contact tracing, supportive isolation. All of that works and is critical. We still need to be ready with local surge capacity, and we've got improving therapeutics. And Jim Wilson can talk much more about some of these things which he's working with daily. So where are we? This is, let me just take a minute. This is, as of yesterday, the average daily new cases per 100,000 population over the last week, averaged out. And so we can see that for most of the high income countries, they're under 5 new cases per week. So the scales are different just because, so most countries are down at about this level here. Spain's seeing a surge, Mexico's there, but we're still up here, only beaten by Brazil. And so we have cases going up. And we've started to see plateaus in a number of states, Texas, Arizona, and hopefully that plateau will bend down. And that's really what we want to see. But as you've seen, it takes tremendous effort. And so what happens in the next 6 innings? It's really up to us. When we look, here's the reported cases. Daily cases with the U.S. We thought we were okay there. We kind of didn't stay with it, and now we've got this. This is really the first wave in a different part of the country, and we're still, the death rate is now, it lags, but the death rate's coming up. 1,000 people a day. At that rate, it's 1/3 people if we stayed at that rate. So what's the way out? I mean, oops, sorry. Big picture, some people are sort of saying we can just let it go and develop immunity. That'll take years and a real toll. And we're not sure how durable the immunity is, depending on the severity of your infection. Vigilance, what you might call herd behavior. Enough of us practice those personal protective habits. And hopefully we get a vaccine. And there are some very promising vaccines. But those are the scenarios. And it's really between the virus and the vaccine developers with now 24 vaccines headed into human trials, and 11 vaccines in the second or third phase. It's really promising. I think unlikely that we'll get fully protective vaccine with the first one, but we have our own choices to make on how vigilantly we respond and get this herd behavior. When enough of us are practicing those personal protective habits, and we really take advantage of the innovations that are going on, and also ramp up the testing. And I haven't talked a lot about that, but we, as a Rockefeller Foundation, we've been very pleased to catalyze a 7-state collaborative to make a major purchase to scale up antigen screening tests. So there are some very hopeful signs. I think, looking ahead, I think there are ways to break the cycle of panic and complacency. It isn't complicated in the sense that there's not a mystery about the things that we should be doing. It's just really difficult to make all those things happen. So thank you, Maureen. I think I maybe have run over a little bit, so hopefully we'll have time.
That was fantastic, Jono. I really appreciate it. And yes, to our audience, we will probably run a few minutes over so we can catch your questions. That was a fascinating talk, and I am very grateful that you were a helpful COVID communicator in your language. So that was really helpful. I would like to turn it over to Jim Wilson to give a little response, and also to put it in the context of some of the things that are going on currently in Nevada. So Jim, are you there?
Yeah, I'm here. Okay, so I guess from our standpoint, we've been monitoring the world for a while now. I think the challenges in John will tell you, we had, an interesting conversation a couple of days ago, and he could tell that I was pretty frustrated as a professional doing this kind of work. There's a lot of boom and bust in the investment cycle in health security and public health. And we're seeing the outcomes playing out. And I think that the hell that I've lived in for 25 years. So Jono was mentioning the 90s, when the IHRs were being looked at, and the team at WHO was looking at new ways of monitoring the world and how do we share information. That came during a time when Hollywood kind of came up alongside that, the media came up alongside that, and we had a huge push to sensitize the global public to these issues in the form of novels, popularized novels, documentaries, as well as Hollywood, right? So lots of movies, and it kind of became a double-edged sword. And Maureen heard me say this a few times, so did Timothy, that as a rising professional coming up through that, you're on board with worrying about pandemics, right? But what we found was that there was so much noise and sort of end of the world kind of talk around these types of events and all the tabletops and worrying about this and worrying about that that we found that it was extremely difficult to arrive at a place of balanced assessment where we could kind of remove the noise and come down to what are the serious sort of non-emotional conversations we can have around these issues to best manage the risk, right? And so I led a team that provided an extensive amount of tracking information on H5N1, for instance, the avian influenza in the mid-2000s, where a lot of experts had given counsel to the White House that it was going to be a global pandemic, a super pandemic, that the case fatality rates were through the roof. You know, we're gonna have millions of people dead. And we went through several rounds of that kind of a cycle, right? Where just a lot of noise, right? You know, and where do you arrive at the thoughtful assessments? And you've seen that play out now with COVID. So the current stats right now, you know, I said this before in the prior talks, it's this constant cycle of trust but verify, right? We know the numbers are not standardized. We know the data and I'm not going to name names, but there are some states that have done some interesting things with their data. You know, we don't want to get in a cycle of blame here. We don't want to get in a cycle of, you know, one political end of the spectrum versus another. You know, I can't care about that from my point of view. I have to kind of look at, okay, well, what's reported, and then what are other sources of data that can kind of back that up, support it, resolve any uncertainty to the best of our understanding. So one of the tactics that we're doing right now is we're monitoring the planet for former hotspots that have seen excessive rates of fatality, okay? So a classic one that the media has beaten up quite a bit is Sweden, right? So they hit about 55 fatalities per 100,000 last time I checked them. They've had an ongoing decrease of ICU admissions for months now. This is in the context of a resumption of baseline social mobility, right? What's interesting is when you compare them to Norway, Norway's had a far less, like 5 times less fatalities per capita, you know, per 100,000 population. They are resuming social mobility baselines. And we're kind of waiting to see, are either of these countries going to see resurgence, right? And the reason why we're doing that is because we're looking for evidence of herd immunity. The problem with assessing herd immunity is much of the studies have focused on antibody testing, right? And we know that there's a whole nother component to immunity that's confounding, you know, our understanding of what's going on related to the T cells, right? A whole nother component of the immune system that we actually don't have tests for and we can't quantify, right? And so our fallback position as analysts is we say, well, shoot, you know, if we can't resolve some of these key cornerstone pieces of information, we're going to have to look at fatality rates. We're going to have to look at ICU admissions. We're going to have to look at other data that's a little bit more difficult to argue the validity of. We're also looking at countries that have previously been praised by the media, right? And praised by public health experts to say that, okay, these countries did an excellent job. And yet now are seeing tremendous resurgence, right? And we've had a couple states here in the US that have kind of experienced that problem. And I think what this whole broad landscape has shown us is this is here to stay. We're going to have to manage our way through this. And at least from what I'm seeing for our state, it really is a balance of how do we manage the demand placed on our acute care infrastructure without, you know, and keep the revenue flow high enough to maintain financial viability of these hospitals, right? Which that's really tricky because they have to manage all the other stuff they typically manage. And up to this point, these hospitals have been operating in just-in-time capacity levels. So that doesn't give us much wiggle room for surge, right? At the same time, you know, if we go in complete lockdown, right, or if we really go aggressive with full-on social distancing to the point that our economy has slogged down and our unemployment keeps jacking up, then we've lost the public trust, the public compliance piece to this. And so it's this balancing act, right? And I think the hope right now is that we're going to hit some kind of level of herd immunity. And I know that that's a controversial topic. There are many public health experts who recoil in horror to say that that's really the end game, but we don't have a vaccine. We don't have a safe, effective vaccine that's accepted by the public. That's the other dynamic, is will our anti-vaccination groups sort of rise up and cause some static in terms of the acceptance of that vaccine? There's a lot of other dynamic going on here as to what the prospects are for reining all this in. We do know that there's test capacity issues. We have supply chain issues with the testing. The turnaround times are excessive, many days, and in some cases weeks. So the prospect of linking testing to contact tracing, you know, it's a nightmare. The demand has exceeded our national capacity to really do things the way we would like to do them. And so what we're forced to do now is sort of look at the lesser of a couple of evils. So in summary, I think for Nevada, we're doing a fantastic job given the degree of uncertainty and the unbelievable complexity that we're trying to manage here between the political constituents, the media, the social media has just been just a mess, right? And the principles that we would like to be able to apply to all this.
Thank you, Jim. That's really helpful, and it does put it in context of what we're dealing with, what we're looking at, and many of the factors that you've been grappling with and Jono has been grappling with ongoing. So with that, before we turn to the Q&A from the audience, Mike, I'd like to turn to you to put this in a security perspective. So bring us back to the issues that you see from a DHS perspective.
So I think one of the biggest concerns that I see is that this topic has become very politicized, and it is, I feel that it is unnecessarily dividing people, and that type of division and mistrust in experts' opinions and those types of things is leaving us vulnerable. And I think it's also because it becomes an emotional topic. When it becomes an emotional topic, we stop looking around at everything else, and we become very focused on that one piece because we're emotionally driven and we're not using logic, and we're missing other things. We're missing preparations for all the other hazards that we need to be focused on: upcoming elections, Iran, wildfires, hurricanes, etc. And we ignore those things because they're not the soup of the day. But we're also being driven by our emotions, and we shut off our brains. And like I tell my teenager, you got to stop feeling, you got to start thinking. And that's what we have to do here. And I'm concerned that we are putting security, holistic security, in jeopardy. And when more people come sick or the next pandemic comes around, our critical infrastructure is going to be hit hard. We're going to see wastewater treatment plant workers being quarantined inside the waste treatment facility for multiple weeks because they're the only ones who are healthy. Meanwhile, their attention is divided because their family's sick or they're tired and they just want to go home. And I see that affecting security. So when we start impacting our critical infrastructure workers, because we politicize this and because we're divided and because we're not paying attention, we miss other things. So I think that's in a very quick overview. I think that's one of the biggest ways that this is going to impact security. Also, we have those unintended consequences. Like, and I mentioned a couple times ago, when things start shutting down, we see how interconnected our supply chain is. We see how interconnected our raw materials are, and all of a sudden we're left with a run of toilet paper and no milk and no meat and those types of things that the normal public didn't see coming. And because they mistrusted the government when we tell them, be prepared for this amount of time, do these types of things. So it all comes back to and Dr. Jono mentioned it when you were talking about the response, and I got really kind of Twitter-pated about it. You mentioned the crisis communications, and I think that crisis communications is a cornerstone of any successful security and emergency management program. And the public trust is that foundation that the cornerstone is on. And you've got to have that public trust. So when you say X, Y, Z, they believe you and they carry out those protective actions, whether it's evacuate in the face of a dam failure or a hurricane, or it's to wear a mask out in public, or it's to wash your hands more often, those types of things. It all comes back to crisis communications, which is based off of public trust, which is totally eroded because it's been politicized and it's been emotionalized.
Thank you, Mike. And I appreciate you bringing up the point of the concurrent emergencies. As many of you in Reno are quite aware, we had numerous fires burning in the city and around the city and throughout Nevada and the country. And those firefighters are challenged by having to fight a fire while under social distancing guidelines. It's been really difficult. So let's go back to some of the early things that you said at the beginning of the talk, Jono. Why is it that so many of the viruses from flu and coronaviruses come out of China?
Well, for coronavirus, it's pretty clear. Well, actually, it's different for the two viruses. So with influenza, it's the most, as I mentioned, the most mercurial. So it's got sort of 8 main genes to it, and those are constantly being shifted around between viruses, and there's mutations, and that happens when you have live animals. It's a kind of a interchange between humans, between swine, between poultry and migratory fowl. And so there are a lot of opportunities just because the sheer magnitude of those animals and people in China, and that contributes to that. With the coronavirus, the biggest reservoir is bats, and there's just reservoirs of bats there, and so it's that ecology. Probably some of it associated with food markets. It's actually not clear that's where this one slipped into the human population. But the live animal markets, both in China and they call them bushmeat in Africa, those are our transmission points which need to be phased out. There's so much of an economic and cultural entanglement that it doesn't work to just ban them, because they go black market and get more dangerous. So those are the kind of points of vulnerability that we need to be collectively working on.
Excellent, thank you, Jono. Before I go to treatments and mitigation measures, let me follow up on that. You made the statement, Jono, early in your talk about Ebola, that Ebola was never going to go global, it was always going to stay regional. Can you give a little bit more insight as to why Ebola we haven't seen a global pandemic on Ebola, and why do you think it will continue to stay regional?
So basically, because it's at least a couple of things. One is it's really direct contact with bodily fluids. And the other is that it becomes symptomatic fairly quickly and very symptomatic. And so you're able to catch it quickly. And that's why actually 6 months before the outbreak of West Africa, there's a scientific group called the Oxbridge Biotrust. They called Ebola a dead-end event because they thought it would burn out so quickly, not imagining it could get into a slum. So it's much easier to contain because it's direct contact, and because it quickly becomes symptomatic. In contrast, the big problem that we have with coronavirus is that the current version, because each of the 3 that have gone global, I mean, there are 4 coronaviruses which are common cold kind of viruses. Yeah. The 3 that have gone global have each been quite different.
Right, and you have this period of latency where people are spreading the disease and either not showing symptoms or may never show symptoms. Right. Much different with Ebola. So let's go to this is a medical question, and this is a personal question, and it also involves a communications question to you, Mike, but also to Jono. We're hearing the realm of countless number of companies that are developing the vaccines, right? So, and they're being tested, and they'll be tested for efficacy, and they'll be tested for safety, which is all very complicated. How do you as an individual decide that I trust the information I'm getting sufficiently when they say, okay, these vaccines will be available or they'll be available for some of the population? What are we looking for in terms of communications? I don't want to ask you what company you trust, but I want to ask you, how do you know to trust the communications such that you know that you should go get a vaccine?
Yeah, so there's a lot, there's a lot of vigilance on this right now, and the concerns have been raised that we're of going too fast. The reality is that you're going to need so many patients. In the clinical trial that's about to start with, one of them is 30,000 patients, and you want to start with the patients that are going to be, or the people that are going to be your highest priorities. So and in the end, it's the US FDA that is going to be assessing the quality of the clinical trials. So I fully expect that companies are going to be expected and will have enough patients that are in those last stages where you're doing it large scale, people at risk, looking at side effects and looking at effectiveness. I mean, that said, side effects that happen maybe once or twice or 5 times in a million cases, you're probably not going to see until you have large scale use. So, but that's true of any vaccine, and so there always will be a very small risk, but I expect we're going to see adequate numbers to get the safety and efficacy for the groups that are intended.
Excellent. And then I'm going to turn to Mike on that, because you mentioned the issue of communications. Is there an effort right now underway to improve the efficacy and the trustworthiness of our communications in such a way that we do avoid a potential security issue of people being so fearful they won't take the vaccine? Is that something that is being discussed in your community?
I haven't seen anything as of late that would indicate that we're focused in that direction. I have no doubt that the public health officials, both at the federal and the state level, are working towards a media campaign and education campaign to promote the efficacy and for people to go out and get the vaccine. Within DHS and CISA, I haven't personally seen that. Unfortunately, vaccines have already been politicized and they've already been emotionalized, if that's, if we use that word. And it's going to be, they have an uphill battle to face when they're talking about vaccines, and to trust vaccines that have been pushed and developed so rapidly without a lot of proof behind them. Not that they're invalid or they're not trustworthy, but the public perception they're in. And so I have no doubt that they're working on that, and I know that's something that they're constantly working on, is to promote those types of things. But inside the security realm, not so much.
That's an important. Yeah, please, Jono, go on.
I think that pandemic literacy is something that we need to start developing early in school, and it's actually not just pandemic literacy. It's understanding. I mean, we haven't come to grips with the fact that we have created a much more complex and intricate world, which has lots of benefits and all that. But we can't keep spending on preparedness and protection and security and all that as if we were still living in 1950 and expect we're going to keep ourselves safe. And so I think that's got to be a fundamental mind shift. And that I mean, you know, we are at risk of doing ourselves in as a species if we don't take seriously the complexity and the increased risk that we've created for our planet.
I'm going to piggyback on his piggyback. I completely agree. And unfortunately, being a former law enforcement officer, I have to say this with gritting my teeth. But the firefighters have done an amazing job educating children on fire safety and stop, drop, and roll and those types of things. But what kid knows think before you click? And that way they don't violate cyber safety protocols. What child knows run, fight, hide for active shooter protocols? What child understands, to keep your head on a swivel and to understand maintaining your surroundings rather than doing this as they're walking into the street, almost getting hit by a car. And I think we've got a long ways to go for emergency preparedness, and starting with the preschoolers. It starts with stop, drop, and roll. It starts with think, don't click, or think before you click. And there's so many areas we're missing. On fire, we're way up here. On security, we're down here. In public health, we might be somewhere in the between, because we tell them to wash their hands. We tell them to take care of themselves and those types of things. But there's so much more we have to do. And I think you're 120% right when we say it needs to start in the schools. It needs to start in the elementary schools. It needs to start in the preschools. It needs to carry all the way through. There's mandatory classes in high school. There's no reason why there can't be a mandatory preparedness class or something along those lines that focuses on holistic security and holistic emergency management and these types of things right here. I can't agree more.
Excellent. Thank you for that point. I'm going to jump, probably this question is probably for Mike, but you can punt it if you don't want to. We're obviously seeing a spike. Jono put out that chart that showed Nevada was not doing so well in terms of the rise in cases. Obviously, Nevada was challenged economically to reopen and get the economic engine going back in the state. We've suffered huge losses in the state. But there was a push to reopen the casinos quickly. And a lag of requiring masks in casinos and not necessarily screening visitors. Do you think that contributed to our rise in cases, and are we in a better footing now?
Man, I really want to punt. So my gut will say that I think it depends on how we're counting the numbers when we're talking about Clark County. So if we have visitors going into casinos from out of the area and they're not feeling well, and they go to the ER inside Las Vegas, and they get diagnosed inside of Las Vegas, I don't know if the numbers count towards Las Vegas or if they count towards our home of record. And if they count towards Las Vegas, that could very easily speak to a spike that's not really inherent to us or to Las Vegas. It could be that they're actually counted at the home record. And unfortunately, my ignorance in this is allows for an incomplete answer. And it's something I should probably know, or probably have access to know, and I just haven't looked at that. But I think that part of the Las Vegas charm, so to speak, is that anything goes. And putting face masks on and being protective is directly counter to the allure of Las Vegas. And without going too much into a personal opinion or anything else, I'm not sure why that decision was made, or whether it was made too late or just in time or not. And without knowing those pieces, it'd be really hard for me to give a good, educated, official answer that I would feel trustworthy.
Well, thank you for that. And sorry to put you on the spot. I did ask Caleb if he wanted to join us today, but he's a little busy these days. Jono, Caleb Cage is a NSF supporter and on my committee, and also the COVID coordinator for the state of Nevada. Okay. I'm going to ask you one more question, Jono, and then Keith, I'm going to turn it over to you for any final questions. Jono, you talked in the beginning about the increase in death rates and excess death rates, right? So I want to touch on this because you went past it very quickly about SARS, and this is also looking at the long-term tail, the tail that could be a health tail, the tail that could be a security tail, and that's the the potential for long-term health impacts from both those who contracted COVID and may have lingering health impacts, and from those who avoided medical care and may now be a burden on the healthcare system with things that could have been treated easier. Is the public health community looking at this, and is there, can we get ahead of the curve? What might we be expecting?
Yeah, no, absolutely. I mean, that is one of the things that we're looking at. I mean, I think the last number I saw was that the cancer follow-up visits are down by 25%. And you can understand the logic of that in the sense that those are going to be people who the medicines or the cancer is going to make their immune system less responsive. So what I think one of the things that events like this do is they do stimulate human ingenuity. And so, I mean, I just had my first, I thought I was going to be at the doctor's office this morning, and I got a call yesterday. I just had my first video doctor's appointment, and so I think, yes, there's real risks, and those risks are particularly big when we talk about missed immunization and things like that, but also missed chronic disease follow-up appointments. And so I think the adaptations, the increase in telemedicine, which is good. I think those are the things we have to do, because one thing I don't think it's wise to do is to figure, well, we'll have a vaccine by spring, and so I just need to get through the next 6-8 months. No, I think I would get habits and practices in businesses and schools and all that are durable for as much as 18 months or more. Back to Jim Wilson's point, is going to be with us. It's here to stay, but it doesn't have to stay at a high level if we are really vigilant.
Excellent, thank you. And Keith, do you have any last questions to wrap up? So for Jono or Mike?
Yes, please, Marie, thank you. John, I want to come back to more of a global perspective on the genesis of these pandemics. And you pointed to China and to Africa and the way the animal husbandry commingles with human existence, and the density of it all makes it a sort of a petri dish for future pandemics. And this also then gets into the issue of China, which, as you know, is a political football to some degree in the US. And the dust up that happened early on in this, accusing China of having finagled WHO to ignore China as a source of this pandemic. How would you react to people who are now increasingly concerned that China, for whatever reason, is really a problem for us health-wise, not national security-wise in terms of military and so on, but health-wise, and that does the WHO really protect our equities in dealing with China?
Good. So a couple of things. One, on the sources of pandemics, it's important to realize that they actually can come from anywhere. The 2009 pandemic, which proved the virus misbehaved from the point of view of the people who I think rightly caused a worry sign, and that actually came out of sort of simultaneously California and Mexico. But I think that I guess a couple of things. The World Health Organization is a member organization, and we got 192 members in it, more than the UN, and the Director General is accountable to everyone. And Dr. Tedros, the two leaders there in this area, Dr. Tedros and Mike Ryan, I've known for years. They're people of real integrity and commitment. So I have confidence in them. Like any organization, you'll have some people who I mean, there've been a couple of what I would call tactical misjudgments or missteps. One was about the asymptomatics, and I think one was maybe an early, just by in the context of one visit under statement. But I think the bigger picture is that China really moved infinitely more quickly than they did in 2003. Getting the viral genome up there literally within days. And already, I mean, that alone, that was a historical thing. And being able to download from the web a diagnostic company in the US to start working on a diagnosis. I do think what it does reveal, though, is at the front line, and this happens, it's not just happened there, it's the vigilant frontline health workers who say something different's going on here. That's what happened in China. It happened early. And the first delay was a reflex kind of bureaucratic delay, which was worse in the China culture than in the than it would have been in another culture. And I don't think, I haven't seen evidence that there was a higher level cover-up. I mean, that said, two other points. We won't know for a while, and we may never know the real pathway, because there was some virus out in unrelated communities earlier on, and the coronavirus experts had expected this anyway. The bigger picture is that the World Health Organization is basically the organization that worldwide is charged with, by our own treaty commitments and collective agreement, with looking after the health of the world. And I think it is absolutely important that we do a mid-action or after-action review. And if there are areas to strengthen it. But I can tell you, if the World Health Organization is the only group that's provided international leadership. We haven't had a Security Council meeting of significance, and they've been providing the data, subject to the flaws in the origination that Jim mentioned. They were already ahead of getting training and programs into Africa while everybody was still looking at Asia. Have coordinated multi-country drug trials and vaccine trials in a way that would be difficult for any perceived regionally biased group. So in short, I think it's an essential part of the global architecture, and it's unfortunate that the U.S. has signaled that it's departing, but we really, as a world community, we really need that central information source, leadership, place where experts can come together and share their views, and that can really provide the sort of support to the lower income countries and all that they need to strengthen their own protective systems.
Thank you, Jono. That was really helpful. So on a closing note, I just hope that you are drafting a COVID epilogue to that book of yours, and that you would be willing to share it with us, or at least let us know when it is available. We will, for all the attendees, thank you for staying for the extended Q&A session. And we will be posting a video of this event on the NSF website. Please join us for our next presentation, which changes gears back to domestic extremism in September. We will be sending out some newsletters with some relevant things for you to follow in the interim. And I hope everybody stays healthy and safe in this challenging time. And I thank you very much to Jono, to Mike, to Keith, and to Mandish for joining us today. And please be safe. We look forward to seeing you soon.